Good afternoon. We'll get started while we let people enter the meeting. I'd like to welcome all of you to Medical Grand Rounds. Just before we get started, I'd like to make a brief land acknowledgement. McGill University is on land that has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous people whose presence marks this territory on which people of the world now gather. Welcome to Medical Grand Rounds. Just a reminder to please leave your questions till the end. Please enter the questions in the chat. As well, please answer a brief survey that will be sent to you immediately after the rounds. This will let us know that you were present today. I'm very, very pleased today to bring you a speaker outside the Department of Medicine, but I think somebody who crosses over the surgical and medical missions very well. Actually, surgical, medical, and cancer missions, Dr. Ferri. Dr. Lorenzo Ferri, known to many of you, is a holder of the David S. Mulder Endowed Chair in Surgery and a tenured professor in the Department of Surgery and Oncology at McGill University. He is the director of the Division of Thoracic and Upper Gastrointestinal Surgery and heads the Upper Gastrointestinal Cancer Program at McGill University. Dr. Ferri couples this clinical activity with an active translational and fundamental research program investigating the mechanisms of therapy resistance in gastro-esophageal adenocarcinoma and the inflammatory basis of cancer progression. For this, he is the recipient of numerous peer-reviewed grants from the Canadian Institute of Health Research, Canadian Cancer Society, U.S. Department of Defense, and a grand challenge from Cancer Research UK. It's a great honor to have you here, Dr. Lorenzo Ferri, today. The floor is yours. Thanks, everyone, for joining us.
Thank you so much. Does anyone hear me, and do you see my video, my presentation?
Yes and yes.
Excellent, perfect. Absolute pleasure to be here. I'm talking about something that's, yes, it's cancer, yes, it's esophagus cancer in particular, but the concept, I think, is common to many diseases that all of us treat here, not specific just to cancer. The concept of bringing next generation disease modeling to patient care, and how do we integrate that into one of the main, the sort of fundamental mandates that our center has, our hospital and university has held, which is really precision oncology and precision medicine in general. So I'm going to use esophageal cancer as a backbone, but the whole concept is something that I think is definitely translatable to other disease sites. So these are my disclosures. There's not enough of them from the speaking honoraria, but compared to some of my oncology colleagues. But the current grants, these are all here, and a lot of the work that I'm going to be talking about has been funded by these sort of large team grants that I'm part of. So my overview is to try to find a way of improving cancer outcomes. I'm going to use esophagus as an example. So I'm going to talk about what the ideal approach for neoadjuvant therapy is very briefly, highlighting some work that was done at this institution. Look at the concept of functional precision oncology and functional precision medicine, and what does it mean, and how do we select the right treatment for the right patient. And finally, I'm going to talk a little bit about some of the current work that's been done in my lab, which is very translatable, and that's the overcoming therapy resistance. Throughout the entire theme of this talk, I'm looking at how next generation disease modeling actually is integrated into each one of those components. So, well, this is a disease that I treat mostly. I do lung cancer as well, but esophagus cancer is sort of the area where they have sort of an international reputation. Now, most patients with esophageal cancer present with at least locally advanced disease. This is a gentleman I treated many years ago. He was 28 years at the time. Luckily, he's still alive. He was one of our first trial patients that we treated on a trial I'll be talking about in a second. Here is a tumor in the esophagus. Here you can see it right here on the CT scan. Now, we know that surgery is the best chance, gives the best chance for cure for this disease and many other solid organ malignancies. However, despite our best efforts, most of our patients with this cancer, and many cancers as well, will die eventually of metastatic distant metastases. This is due to a number of reasons, but it has led to us recognizing that we have to do something else for these patients. And many of our solid organ malignancies, surgery alone is not enough. We have to have something else. Two main viable options for esophageal cancer, but again, this can be done for any other malignancy, is chemotherapy, radiation therapy, either before or after. whole bunch of different ways to look at it. We've been luckily we've been at the forefront of this globally, and some of the studies that we did here at this institution have really paved the way to the current treatment of esophageal adenocarcinoma. This is the first trial that I wrote when I first came back on staff with my good friend and classmate Steve Naddis, who's now down at University of Vermont. We looked at, we knew that the patients were failing, so we decided to try something, a docetaxel-based triplet therapy to see if we can give it before surgery and if we can improve the outcomes. This is, again, notoriously, esophageal cancer has notorious poor 5-year survival, hovering around 15 to 20%. And we showed with this highly aggressive disease, and this highly aggressive disease with this relatively aggressive chemotherapy, we can improve survival significantly. There's a phase 2 trial. But right when I was presenting this at ASCO, right to the next to me was a guy from Germany who took this and modified it slightly, then presented this data, which is a FLOT4 trial. I promise there's only going to be 3 survival curves. For those of you who've seen oncology talks, I try to limit it and try to give big concepts rather than a whole bunch of Kaplan-Meier survival curves. So there's 2 more, and that's it. So this is a trial. The guy to the next to me is Sal Albatran in ASCO in 2010 when we both presented this our data, and he went on to a larger phase 2/3 trial in Germany showing that FLOT, which is very similar to the docetaxel-based triple therapy that we had been used, was superior to what was being used at the time, called ECF, and that has now been the standard of care for gastric and esophageal gastric junction cancer. When we first started using this in North America, maybe 5 years ago, we had a lot of pushback from some people because they said it wasn't done in esophageal cancer. So we collected, again, this is retrospective data, but we connected data from McGill with Trinity College Dublin and the UK, showing that it's also very effective for esophageal adenocarcinoma as well as gastro-esophageal junctional adenocarcinoma. So because of this, that's the only 3 survival curves I'm presenting. Other than that, it's all big picture, big concepts. Because of that, now docetaxel-based triplet therapy is now the standard of care for locally advanced esophageal adenocarcinoma. And this is sort of what it looks like. This is the patient I had, the 28-year-old gentleman that I treated. He was maybe the 3rd or 4th patient on the trial back in 2010 or 2008. And we gave him 3 cycles. We gave him neoadjuvant chemotherapy. At the time of surgery, we resected him. He still had a large amount of tumor. Then, as the trial is designed, we gave additional 3 to 4 cycles of docetaxel-based triplet therapy adjuvantly. That's a current standard of care for not only esophageal cancers, but for many locally advanced cancers that we see in any organ site. So that's the general idea. Unfortunately, most patients do not benefit from this blind approach to patient care. We are just looking, our only decision-making, the only biomarker that we assess here is histology. That's actually even simpler than that, it's location. That's the only biomarker. It's a poor biomarker. Where is the tumor located? And why is that? Because most patients either have a high rate of resistance. These tumors are either innately or they acquired a resistance. In this cancer, it's particularly bad. In other cancers, it's even worse. So I'll give you an example of what that looks like. So this is a patient, 74-year-old woman we treated maybe 3 years ago on a different trial. She had very large gastro-esophageal junction adenocarcinoma. This is right at the cardia here. After 2 cycles of the same docetaxel-based chemotherapy, she's had an excellent local initial response. The tumor is reduced significantly. And then right before surgery, after all cycles, it's pretty much gone. And a PET scan confirms that. You see a huge tumor here. And after 4 cycles of chemotherapy, it's gone. This patient was well suited and benefited well to the current standard of care. Her tumor is highly sensitive. Indeed, she's done very well. She remains in remission. That is what we will hope to have. But we know it's probably around half of our patients, maybe a third or a half, sometimes even more, depending on the malignancy, depending on the cancer. It's not the scenario. This is another gentleman who had 2 small cancers, a 58-year-old gentleman we treated more recently. He had a Barrett's cancer both on the left-hand side and another secondary tumor here. And we gave him 2 cycles of chemotherapy. There's some ulceration showing some initial mild response. But afterwards, the tumor seemed to be tickled by the cancer and actually progressed. Indeed, on PET scan, he developed a liver metastasis. So this patient was not well suited by the treatment. The tumor was resistant to this cancer. So the concept, this is unfortunately this is the best thing that we have going right now. We base it on histology and location, and then we choose a certain treatment. Now, how do we select the effect? How do we effectively select the most effective treatments for each patient? How do we choose the ones that are going to be winners and use the right treatment? And those who aren't going to be winners, who aren't going to have benefit from this treatment, how do we find the right treatment for that? So that gives me the concept of functional precision oncology. So traditional care, so we challenge the current treatment of not only esophageal cancer, but all malignancies right now, solid organ malignancies. So I can tell you hematological, they're a lot further ahead of us. But for the solid organ malignancies, most of us are treated the same way. We have a traditional care where the treatment is based solely from on the organ from where the cancer originates. Tumor in the lung is treated like a tumor in the lung, tumor in the liver is treated like tumor in the liver, colon, esophagus, breasts, all treated very similar. And we're lucky if some tumors, there are some certain biomarkers. In lung cancer, melanoma, there's tons of biomarkers. In esophagus, there are not that many. This is a list where we have right now. It's really only 4 long. FGFR2 has it not ready for prime time. So this is what we call about precision oncology. You choose a biomarker and you identify treatment based on that biomarker. The problem with that, another way to do it is that often we don't have good biomarkers. So we send the patient may pay for foundation medicine. They send their tumor for sequencing. However, in the vast majority of cases, in some cancers, particularly the one that I treat, esophagus cancer, there are very few actual mutations in some diseases. And this is particularly true in esophageal adenocarcinoma, which is characterized not so much by mutations, but by amplifications. So even if you do this precision oncology and look for mutations in the cancer, very often patients are left and clinicians are left with few options because we don't have any action mutations. So what is the next concept? How do we, even if we do the traditional care or precision oncology, irrespective, it's still a trial and error approach to patient care. No matter what the cancer is, no matter what disease is, we see a disease, we see a cancer from this area, we select something that's maybe the best option based on a trial of 5,000 patients or 2,000 patients or 100 patients, and we try it out on the patient. If it doesn't work, not only have we done the patient a disservice, we also lost a valuable time, and also we've increased toxicity for ineffective treatment. So how can we improve on that? That brings me to a concept of functional precision microbiology. This is basically for the past 100 years. Microbiology, we've been doing functional precision microbiology, and that concept we need to apply to other disease sites. For example, if you suspect pneumonia, this is the patient of mine who underwent neoadjuvant chemotherapy. You can see pneumonia right lower lobe. You isolate and grow bacteria in the sputum sample. You do ex vivo testing to determine which antibiotics are most effective based on an initial panel of the species. And based on that, we select the right antibiotics. We tailor the antibiotics to the patient. Now, I apologize if I'm simplifying this for microbiology colleagues who are on this call. But that concept of functional precision microbiology, couldn't we apply that to cancer? Shouldn't we be able to do the exact same for cancer so we know exactly what treatment is going to work in that patient? That's a concept of functional precision oncology that we really try to pushing forward quite aggressively in our division in the past 10 years. So why did we do it in the past? Well, we didn't really have adequate cancer models. The ones that we're most familiar with, this is we looked at this right here, cell lines, cell lines. This is, again, we've been treating the HeLa cells or the Henrietta Lacks cancer cells over the past 70 years. We've all cured them in the lab multiple times over, but they're don't really replicate the actual tumor that we're trying to it's not very accurate representation of the patient's individual tumor. So a group in Utrecht developed a technique of culturing primary cells that maintain heterogeneity, and that's the organoids. So these are patient-derived organoids. It can be either from tumors or benign tumors or benign conditions or normal epithelia. They're basically three-dimensional cell cultures, usually between 1,000 and 3,000 cells. They're self-organizing. They're stem cell-based. Their primary cells are not modified genetically in any manner way, and they maintain the heterogeneity of the primary tumor, as well as the function of the primary tumor. So until we've had this ability to generate these cells on a high throughput manner, we weren't really able to even explore the concept of functional precision oncology. So our lab has been really invested very heavily in this over the past 10 to 12 years, and we're really looking for physiologically relevant disease modeling systems. The first 15 years of my practice in the lab, every CHR grant I had was peppered in numerous genetically modified mice, and we really sort of lost focus on what we're trying to treat as a patient. And the patients really don't look like the genetically modified mice that we're doing. So we wanted to do a physiologically relevant modeling of the cancer and or diseases that we're trying to treat. The two areas that we looked at primarily is patient-derived organoids, and using these patient-derived organoids to see patient-specific organ chips. And I'll talk about that a little bit more. Now, although my research labs or my research grants are primarily looking at drug development, mechanism of metastasis, and investigating therapy resistance, we recognize that the platform, in order to generate all this and in order to build this, is prime for a concept of functional precision medicine and oncology in particular. So let me take you through that, what that looks like. So again, over the past 10 years, initially with a push from Morag Park, the Government Cancer Research Institute, we started live banking, sort of next generation banking of esophageal, initially with esophageal and gastric tumors, but have expanded that to lung, mesothelioma, colon, ovarian, based on certain grants and collaborations. So we have over 350 patients that we've either done from biopsies or from the surgical specimen. We do our traditional standard banking that we've been doing since for eons. But in addition to that, we do next generation, both analyses and tumor interrogation, as well as live banking as both organoids, as well as patient-derived xenografts, but we use it only to be able to get more organoids to increase our efficiency rate. So after a long time, this is laborious work, quite expensive work. This was initially funded by philanthropy, but now we have leveraged philanthropy to get a significant amount of peer-reviewed funding in order to continue this project. So as you can see, the initial success rates are quite low, both patient-derived organoids and patient-derived xenografts. But at this current state, around in 2023, we have around a 75 in combination between the two. For a single patient's tumor, we have a combined success rate over 75%. Now, this has taken a long time to get there. When we first started, around 12 to 15%, 20%. Indeed, most centers are stuck around 20 to 25%, depending on the disease, on the tumor location. But this has translated, our success in this area and our long-standing investment in this area has translated in us having a live bank of a gastric esophageal adenocarcinoma that exceeds 400 patients and is the largest globally by far. For example, MD Anderson probably has 12 or 15. Sloan Kettering might have 30, but we've really invested quite heavily in order to build this. Now, what this does is not only a tool for scientific investigation into certain disease processes, but also allows us to build a platform for functional precision oncology. So in order for these organoids to really be useful as a patient avatars, we have to make sure they either look like it and they act like the patient's tumor. This is an example of tumors that we generated organoids from patients who subsequently went on to get chemotherapy. Some have had a good response, either a complete pathological response to chemotherapy, or those who had poor response or tumor progression on chemotherapy. And you can see this is what the organoids look like when they're alive. This is when they're fixed, and you can start seeing they look exactly like the primary tumor from which they came. This is an example of a patient with a 38-year-old patient with a multi-differentiated adenocarcinoma. This is in the tumor. This is the organoid. Look histologically almost the same. As well as, now there is some selection. If you look at we do sequencing, whole exome sequencing of the primary tumor as well as the organoid. There is some selection of certain clones, but generally they look very similar to the tumor from which they originated. Very different. This is different than PDXs, which there is at least in some cancers, there's a selection of the really bad actors in PDXs. We don't see that. We've been able to make organoids from normal tissue, from metaplastic tissue, from pre-malignant and malignant, well-differentiated, poor differentiated. But there is clearly some selection in some clones. In addition, we've seen that the certain histological subtypes is maintained, at least at the protein level. So if you compare, we have a great resource of microsatellite unstable gastric esophageal adenocarcinomas, and when you look at them, you can see that their loss of the mismatch repair proteins is maintained from the tumor into the organoid. So it really recapitulates the tumor at the protein level, genomically, and you'll see later on transcriptomically. And what's most important is how do they look like? How do they respond ex vivo? Do these organoids react to the chemotherapy in the same manner that the patient reacted? Now I'll show you some organoids. These are organoids that we've generated. They were derived from patients who subsequently, treatment-naive patients who subsequently got chemotherapy. And so we have an inpatient response showing either complete response. So after chemotherapy, that patient had no cancer whatsoever, or they had poor response. And we'll show if we treat the same ex vivo, in vitro, we give the same drug that the patient received. And you can see over 3 days, these organoids basically just explode like the Death Star, if you will, from Star Wars. However, if you look at a poor responder, this is a patient with 3 days of chemotherapy on this organoid from a patient who had a very poor response and progression on chemotherapy. You can see here that organoid just gets tickled by the cancer. So what doesn't kill it makes it stronger. And if you look at the kill curves, you can see all in green. These are all the organoids that were derived from people who had a very good response in patient, and we had the same thing in the patient in the organoids. So the concept is, can we use these organoids to understand, first of all, as well as identify strategies to salvage and overcome therapy resistance? Can we do this up front so we know who to give the right treatment to, who can give the standard care therapy, and who do we have to do specialized things? So this is sort of using sequential organoids and rebiopsying longitudinally in order to give us an idea of over the patient trajectory to understand therapy resistance in real time and try to find ways to overcome it. So let's have a look at how that looks. Let's go back to that patient who had disease progression on chemotherapy. This is a gentleman with the adenocarcinoma, the Barrett's adenocarcinoma, whose tumor had progressed. So at the same time, we try to integrate, we biopsy, we generate organoids at each one of these time points in the patient trajectory. We generate organoids. I'm sorry, we're missing something there. We generate organoids. At the same time, we sample that we interrogate that tumor extensively with a multiome analysis, both at the genomic level, transcriptomic level, primarily at the single cell resolution, and spatial proteomic level. So we're able to use those information, try to integrate them to better understand why these patients are having therapy resistance. Can we identify biomarkers to predict whether or not they're going to respond? And secondly, how can we use this information to overcome therapy resistance? So this is an example of a couple of patients where we've used sequential organoids to understand and help, hopefully in the future, inform and direct our treatment. As a gentleman who had in black is a kill curve in response to docetaxel outside ex vivo in the organoids. You can see it has a very good response to the treatment. Indeed, the patient had a very good response outside the body. Whatever was left out, we rebiopsy whatever was left after neoadjuvant chemotherapy in the primary tumor. We generated organoids again, and again there's a good response to docetaxel. So even though there are some cancers left over, this patient, whatever's left over, still responds, and so it makes sense to continue the same chemotherapy that the patient got beforehand. He was well suited. He benefited from that treatment. Indeed, he's live now at around 5.5 years based on this, despite having a pretty bad disease. Now we contrast that to this patient who had a good response initially. The organoids that were biopsied at the time of diagnosis initially responded. But at the end of it, when we took out the specimen, whatever was left over had become now resistant. It had acquired resistance, either from selection of certain resistant clones or from inducible resistance mechanism from plasticity that drive that therapy response. In this patient, doesn't make any sense to give the same therapy. How do we convert this area here to here? How do we make whatever tumors left over into responding to the therapy? So we clearly need to change what we're doing in this patient because he's not going to be well suited by this therapy. So how do we do that? Well, what we try to do is really integrate the organoids that we generated from that patient with the multi-omic interrogation of those tumors to try to come up with some approach that prevents, overcomes this therapy resistance. This is an example. I'll show you this example of what some of the things that we're doing in the lab and what we hope to be able to translate to the patient very soon. So first thing we can do, we can identify alternative therapies for chemo-resistant, those who become resistant, gastro-esophageal adenocarcinoma. We can look at their genomic drug screens. So genome-educated drug screens based on whole genome sequencing or whole exome sequencing, depending on the grant that we have. Unfortunately, these tend not to work very well because esophageal adenocarcinoma does not have a lot of mutations, has a lot of amplifications, but irrespective, there are some that seem to work. This is an example of a patient of ours, actually a physician who's from Montreal, who had a tumor, and you can see here had EGFR amplifications. He is resistant. His organoids were resistant to oxaliplatin. However, they're sensitive to EGFR inhibition. So that's one way to look at it. It's very crude, and unfortunately, the genome variant directed therapy has largely failed in this disease, where in others it may be more successful, such as in lung and such as melanoma. What about transcriptomic educated drug screens? This is exactly what some of our PhD students are doing right now. Look at the single cell transcriptomics. This is a patient's tumor. And we can see there's a high expression of CDK12. We look at the organoids generated from this patient. This is where we integrate the organoids with the transcriptomic data. And you can see those organoids have high expressing CDK12 as well. And then we can target CDK12 directly with a CDK12 inhibitor. You can see there's some response, but more importantly, there seems to be more synergistic response when you combine it with chemotherapy, the standard docetaxel-based chemotherapy of which this organoid is resistant. You can see with the CDK12 inhibitor, we can target it. This is just an example of the concept of integrating your variant interrogation of the tumors with the organoids and using functional precision oncology. So maybe in this patient, we're best suited by targeting CDK12. Another option is to look at variant agnostic. So it doesn't really make a difference what works, but if there's something that works and it's tolerable, then maybe that's how we should treat patients. So this is similar to what we're doing with microbiology in some things. So we do a high throughput drug screen library. We've been able to modify it so we can do high throughput drug screens on organoids. There's a facility. So we use the library that we use right now is a 3200 FDA approved library that covers all sorts of diseases. So it may not be designed for oncology, but these have passed phase 1s, phase 2s, and they're now FDA approved for a disease anywhere of anywhere in the body. This is an example of how it is. This is at the Montreal General Hospital. We've modified this in order to allow us to do it on organoids, which took quite a bit of work, but we're able to test 32 drugs using these 384 well plates. So it's around 10 plates per patient. After biopsy takes us around 3 to 4 weeks to have enough organoids to generate after the biopsy in order to do a variant agnostic drug screen. This obviously is not possible by hand. It would take days, if not weeks, to do this. This is done in hours. My postdocs and PhDs are extremely happy that we don't have to do this by hand. So here you can test in one patient's organoids. You can test in a matter of hours all 3,000 drugs. So how do we use that information? So we use it just by looking at the data itself. We looked at as well as we can integrate it with the variant data. So we took organoids from 3 patients who had tumors resistant to the standard therapy, and we found drugs that had a 65% inhibition in these drugs. All the ones that worked in all 3 responders, we had a sort of coned down to around 20 of them. You look at them by drug targets. We can start looking for things that there is some commonalities in all these patients. Indeed, and for this example, we looked at IGFR1R. And if you integrate that with the single cell transcriptomic data, you can start seeing the similar patterns are arising. From the single cell transcriptomic data, we see in patients who had poor responders to chemotherapy, they have a high expression of IGF-1R, and IGF-1R is targetable. And indeed, when we target it, we have a synergistic effect with the chemotherapy, making the chemotherapy more effective. This is just an example of how we can integrate the two. And we've actually started a collaboration with a drug repurposing pipeline at the Wyss Institute at Harvard, where we integrate it with actually bulk RNA-seq data with our high throughput drug screening data in order to try to find out what is the best likelihood of drug to use in one patient. So this is where we are right now. That's the beginning, just the start of functional precision oncology. That's what we can do. That's what we are doing in the lab, and we hope to be able to translate into patients very soon. And there's quite a few centers around the world, particularly, including Utrecht, the place that started it all, who are looking at this. But the problem is that organoids are good. They do separate in response to this, but there is quite a bit of crossover. As you can see here, there's some poor responders who are similar to some of the good responders ex vivo. So what is missing in this? There are other factors that seem to be important that can drive not tumor biology or any tissue biology. So the problem with organoids is that they're static in vitro. You basically drop a whole bunch of chemotherapy at non-physiological concentrations. You bathe them in it for three days, which is very different than how drugs see tumor, how tumors see chemotherapy in vitro. There's no in vivo. There's no tissue interface. There's no mechanical stretch, and there's also no stroma. So we know that the tumor microenvironment is really important in response, can be very important in cell biology, tumor biology, and response to therapy. This is a example of Codex, multiplex imaging that we collaborate with Gary Nolan at Stanford for a project we just got accepted, and we show that tumors are not only epithelial cells. We know that. And we know what's interesting about this is looking at its cellular neighborhoods. We find that, some things, so the epithelial cells, the cancer cells are here. But you can see there's immune cells that seem to be driving at the center of all this, and they seem to be communicating with each other. So those things may be important in tumor biology. So they both integrate, they're both sort of at a crossroads between the endothelial cells, the vessels, the cancer cells, and the tumor stromal cells. We look further into tumor stromal cells themselves. There's some work being done by one of my bright students looking at cancer-associated fibroblasts. There seems to be some differences between those responders and non-responders. So we're looking at heterotypic recombinants to see what components of the fibroblast are involved in therapy resistance. And that's all missing in our standard organoids, where we're just looking at epithelial cells. So how do we incorporate all this? So we started initially by doing just co-cultures in vitro. So this is an example of one of my old PhD students. We're trying to get the organoids, which are the big cells, the big group cells, and the neutrophils working in the same ecosystem. That requires a lot of modification of culture techniques. Working with with one of the bioengineers, Matt Kinsella, down at McGill, we've found ways to get the lymphocytes and the cancers, the immune cells, lymphocytes and the organoids in the same ecosystem. And also we've done some static in vitro using air liquid interfaces between the cancer cells and the fibroblasts, and showing that there's differences in therapy response. But again, what we're still missing is a living mechanic system, which is not just very static like we have currently. So how do we overcome all that? Well, I was fortunate enough to work with a great bioengineer at Harvard at the Wyss Institute. We initially wanted to look at mice, but the problem with mice is that it does address the static in vitro. You can give chemotherapy to it. It doesn't deal with the issue of stroma, but the issue is that that stroma is murine. It does lack immune system, and there's a lengthy development. So we really wanted to look for something else. We're working with Don Ingber at the Wyss Institute at Harvard. We came across this system that he developed, which is an organ chip. This has been commercialized. He has since spun off company. This has been commercialized, but we've collaborated with him on a couple of our large team grants, where we're trying to take those organoids and the cells that we've generated from the tumor, including the immune cells, including the fibroblasts, recapitulate it into an organ chip to allow us to really look at how these tumors are going to respond to therapy. So this is currently the most physiologically relevant stromal inclusive cancer model system that we have. There's a few people looking at this. What I love about the Don Ingber's group is that not only do we have flow in here, we apply flow, but we also have to create the mechanical stresses that are important in governing cell biology. So we have physiological shear rates of flow, mechanical stress, and clinically relevant chemotherapy dosing is possible in a organ chip that we have here. So what we've tried to do is generate these patient-specific, organoid-seeded organ chips, and see if they accurately replicate what's happening to the patient, so we can eventually use it, move it prior to treatment, and govern allow us to select the appropriate drugs for the right patient. So what we're doing right now, we take the organoids that we've generated from a patient. These are patient matched. So they're come from the exact same patient's tumor prior to treatment. We seed the luminal channel, which is above here, with the organoids, the epithelial component. We take the fibroblasts into the vascular channel, on which they, after a week, they generate their own extracellular matrix. And we're able to recapitulate a tumor. And we're currently working on 2 cells with the organoids, epithelial organoids, and fibroblasts. Our plan is to go to 4 cells, including endothelial cells and the tumor, the lymphocytes in the vascular channel. So this is what it looks like. We're able to really make those tumors. This is the top view of the normal esophagus on chip from the same patient. This is the top side where you can see normal squamous epithelium cross section. You can have a single layer of epithelial here, followed by a barrier membrane and the fibroblast on the bottom. On the esophageal cancer chip, you can see very disorganized adenocarcinoma, and there's a lot of bunching, loss of contact inhibition, and a tumor that develops on the organ chip. This is after 7 days. If you look at it histologically, it is exactly the same histologically as a primary tumor. This is from the patient's an FFPE of the patient's tumor, and this is the esophageal adenocarcinoma on a chip. It is the exactly same tumor. We've done genomic analysis as well. It's the same tumor genomically. And more importantly, when we give chemotherapy, we can give chemotherapy at physiological concentrations, the inpatient pharmacokinetic concentrations that are given to patients at the same time and same dosing that the patients get. That you cannot do that in 2D cell lines. You cannot do that in organoids. So you actually know how much we can give it for 1 hour, 2 hours, 4 hours, 24 hours, depending on what regimen the patient is undergoing. And if we look at sort of, we compare a organ chip that was developed from a patient that had a chemo-sensitive tumor, you can see right here, these and a chemo-resistant tumor. This is how it looks on a cross-section on immunofluorescence. This is how it looks on electron microscopy, very similar. However, after 1 cycle of chemotherapy, the exact pharmacological and concentrations that the patient received, you can see here almost all the epithelium after 1 cycle, epithelial cells are gone in the chemosensitive. In the chemoresistant, there's a maintenance, there's some reduction, but there's a maintenance of a full layer of epithelium. More importantly, we can see on the on the electron microscopy, cells are completely destroyed on the chemosensitive, but in the chemoresistance, they are maintained. So we've done a whole bunch. This is just a quantification of the same data, showing there's a lot of cell killing, the sensitive ones compared to the ones who are resistant in chip. This is exactly the same waterfall plot as if how the patient reacted. We're able to recapitulate that much better than we can with the organoids. So we've taken it the next, it's a 2.0 live functional precision oncology. So in addition, if you want to, we can use a vascular channel to look at the chip effluent for a number of factors, whatever disease you plan to model. In this case, we looked at circulating tumor DNA. We're looking at cytotoxicities. And so you look at the effluent and see what is being released into the blood of the tumor, downstream of the tumor. So there's many different factors we're looking at. This is an example of some of these biomarkers that we're looking at of responsive tumor burden. So our goal is to use the addition of the shortlisted effective drugs that we've identified from the high throughput drug screening and integrated with a variant analysis, use a selection of top 5 drugs, top 10 drugs that we've done in the high throughput approach, and use it, identify in this high fidelity but low throughput validation. So we convert these chemo-resistant organoids and organ chips to chemosensitive ones. So that's our goal we want to apply to the patients. So there's a lot of excitement in this area. This is sort of in oncology, and as well as I'm sure in all diseases, this is an area we're trying to really they're trying to find a way to get functional disease modeling to patients. It had been tried by our colleagues at Utrecht. They had a lot of difficulty in efficiency rate, even though they developed the technology. They tried it with colon cancer. It took too long for them to develop the organoids, and there were some validity problems. So we've really worked very hard on increasing efficiency rates. So we've gone from around 20% to around 75% of getting these live organoids from patients per sample, as well as reducing the timeline. In this trial here, they had it took them 10 weeks to get a target, which is way too long for patients in this disease. So this is our current platform that we use not only for our all the grants that we have in our group, but also what we plan to do is to offer to patients. So we do a biopsy. Currently, it's stomach and esophagus, but we can do this for any disease site in which we can access to. Based on our current efficiency rates, around 75% of our patients were able to develop patient-derived organoids. By the time we get to the third passage, we're able to passage these to get enough to expand them, to do high throughput drug screening to identify which of the 3,000 drugs in the FDA approved are going to work. In that area, we integrate at the same time, we have data that we can integrate with the sequencing, genomic, transcriptomics. We're doing a kinome analysis at UCSF to see what else we can integrate into this algorithm, this pipeline, in order to help us identify the right drugs. Once we identify a shortlisted amount of drugs at the level, we go from high throughput in the organoid to low throughput but high fidelity organ chip. So we select the top 5 hits. By this time, by 5 weeks, we already have enough organ chips. We can do of every patient's tumor. We can replicate in a 1 per chip. So we usually get 5 or 6 chips at the same time. It takes us a total of around 3 weeks to get those chips running. We'll have the list of highlighted or shortlisted drugs here, identify which one, and give those to the patient. That's the concept they want to do. That's the idea where we want to go. So what is the future, in my mind, what does the future esophageal cancer look like, or any cancer that's solid organ and for which we're able to develop organoids? This is a current model. We want to move away from this, of this trial and error approach. So ideally, we'd like to do this process prior to treatment at the time of diagnosis. I think we're getting close to there, but we're at 5 weeks for us to be able to identify the right drugs. That might be too long to be able to do it before treatment, but we can definitely do it in the adjuvant setting for patients for esophageal cancer. So our current concept, our working algorithm or trajectory for these patients is that everyone gets a standard neoadjuvant therapy. If it does not work, then if their patient has a good response to treatment, there's no other cancer, they're well suited by the chemotherapy. So we continue the same chemotherapy. If they don't have a response to this treatment, then we can identify, by this time, we'd be able to identify which drugs is going to work by using this functional precision oncology platform. So this is, again, it's sort of a bit in the future, but I think it's not that far in the future. We have the platform running right now to the point where we can do this at 5 weeks. And our goal is to bring it to patients in the next year or 2 years. So this is obviously, I did absolutely zero of this work. My only idea, my job is to find money and find ideas. We've been extremely fortunate being funded by some very large team grants that helped us get this off the ground, and also been very, very supportive, had incredible support from the philanthropic community, even to get the project going. Thank you very much.
Thank you, Lorenzo, Dr. Ferri. This is really, really impressive. Congratulations on accomplishing all this. Sort of big picture, is this, all this equipment and what you're doing, is it in your lab only, or is this sort of a platform that's used in other oncology programs?
It is, there's not many centers who have this. What we're trying to do is to develop the expertise and then increase it in scale and geographically. So we've been funded by the by CIHR and Canadian Cancer Society to expand this and try to do this across Canada. So we get the tissue from wherever. Right now we're getting tissue from well, we've just started. We just got the RB collected, but we're planning. Our goal is to get tissue from Winnipeg, Vancouver, Toronto, sent to us by the next day. It's fresh. We grow out the organoids, and we do this program. We give them a drug in 5 to 6 weeks. Our goal is to be able to do this, expand this into both geographically and in scale. This is a platform. The platform exists in my lab, but it's one that we've offered to help others. There's a couple of in ovarian, we've generated the organoids and done drug screens for them. So we're more than happy to collaborate with anyone. The organ chip, that is a really exciting area. We've done it on colon, we've done it for esophagus, we've done it for lung, but we're also willing to work with anyone to help them out. There are many organ chips out there, but I like about this one, this is the most physiologically relevant one that I've found, and the one that's that has the best data behind it. So it's something that's in my lab now, but it's something that's scalable.
Okay, it's really, really impressive. Ingrid, did you want to ask your question, Ingrid?
Yeah, so at some point, maybe you answered the question, but because I was thinking in terms of, is this practical to determine a patient's therapy up front, but you seem to say because it takes 5 weeks that it basically takes too long. So I think you answered that part of it. And the second part is, how much tissue do you actually need to set one of these things up? So is a biopsy specimen enough, or do you need more?
Well, to go to your first question, our goal is to get it to do it in the neoadjuvant setting. I can tell you right now you guys know better than I do how long it takes from biopsy. When I first came here, we were treating people 3 months after their initial biopsy. That's reality. That's how it was. That's how bad we were in Quebec. We are better than that now, but we're not much better than 5 weeks. I think we can get it. If I can get this process going at 4 weeks, I think it's completely feasible to do this in the neoadjuvant setting and even in the metastatic setting, where you may want to start with standard of care, then alter straight away once we have this information, like we do while we're waiting for biomarkers now. We're waiting for PD-L1, we're waiting for HER2, we're waiting for all these biomarkers that may take time. We start with a baseline and we add this later on. So I do think it can be used both in the best areas to use in the metastatic setting. I do what I do. I study what I study, and that's the neoadjuvant locally advanced disease. The second question, we can definitely do it on biopsies. Our success rate with biopsies is slightly lower than it is with surgical specimens because we have more tissue, but we are getting better at knowing where to biopsy a tumor and how much we need. So we usually get 6 separate biopsies. And so that's our protocol that we have. We have our standard operating procedure. When we get tissue from University of Toronto, we ask them for 6 biopsies and we generate the organoids here, and our success rate is good. It's probably in the 55% range as opposed to 65% range from the organoids alone. But it's still, we can do it from biopsies. We don't need large specimens. You can do it we did it from core needle biopsies, from liver. We've done it pretty much from any size that you give us. We go ahead and we're able to generate it. What we end up doing is it's the same biopsy sample we use for single cell transcriptomics. We dissociate, we grow out we grow fibroblasts, we grow out the TILs, and we get the organoids. And at the same time, with half of that aliquot goes for single cell transcriptomics. So a biopsy is all we need.
Okay, thanks.
Magda, you have a question?
Yes, I do. Thank you. Thanks. First of all, I think it's the first time I've heard a surgeon compliment microbiologists, so thank you very much for that. But conceptually, I was wondering if this is a fascinating model, but I was wondering if the core assumption is that the mechanisms of resistance are innate to the tumor cell and encoded within the genome, or is there, and I don't know anything about this particular field, but in microbiology with resistance to antimicrobials, more and more, the mechanism of resistance is actually acquired through mobile genetic elements. So would organoids be able to predict or detect that, or am I missing something?
Nope, you're not missing something at all. In fact, the 2 of these grants right here, this DOD as well as the CHR, are looking exactly at that, primarily at acquired resistance. And it's not, unfortunately, it's very rarely in the genome. And we're finding out these are inducible, just like it is with E. coli. You know better than I do, but E. coli, genome doesn't change, but they become resistant. And that's the idea came to us, that we're doing this all wrong. precisely for microbiology, because it's not at the genome level. Yeah, there are some low-hanging fruit. Some cancers you can tell, some cancers, lung cancer and, fusions, ALK fusions, those respond and they have a good response rate. All of our other biomarkers suck. So it's inducible. In fact, that's why we went to single-cell transcriptomics. We think we're going to find it very early on, early inducible effects. That's why we do a mid-treatment biopsy to see what is emerging. It's not the genome. It's something that's inducible, a stress response. We think, hypothesis, stress response, some Wnt signaling that's activated that creates plasticity that does not require genomic changes. And in fact, it may even further than that. That's why we've collaborated with a group, and well, it may just be the further beyond. It might be functional proteomics where the kinome, the proteins are the same, but the kinome changes in response to therapy. So those are all acquired. I think acquired is going to be, and we see that with immunotherapy. Those of us give it. It's a lot of it's acquired resistance.
Thanks.
Thank you, Magda. Constanza, you have a question?
Yes, Dr. Ferri, thanks so much for this talk. It was very, very interesting. It's so nice to see this coming along. My question is, have you thought about incorporating radiotherapy in the treatment algorithm for this organs in a chip?
I haven't. Well, that's not true. I have. But I'm collaborating. I just sent down organoids to MD Anderson. As I said, we've collaborated with them extensively. We try to get them their live bank process set up. It's not paid for by insurance. So if it's not paid for by insurance in the States, nothing happens there. So their live bank is very small. But they have some that we've helped them generate. We sent some down of our chemo-resistant organoids, and he has some. They have some radiation resistant organoids, and we're looking for some similar pathways. So we have thought about it. We're not doing it here. We collaborate with centers that do more chemoradiation for this disease than we do.
Thank you.
Fantastic. There's a comment here about your machine that tests 3,200 drugs at the same time.
Yeah.
How does it? Somebody's asking for a bit of information on how this is done.
Well, you go to a donor, you get $700,000. $700,000. You buy that, and for each one of those, I'm not joking, it's extremely expensive. It's around $6,000 per organoid because of all the reusable pipettes. So it's as well as the drugs. So what it's done, we grow the organoids. Within 3 weeks, we have enough organoids to seed 10 384 well plates. All the same patient, all the same tumor, organoids in each one of them. And then it's one dose of chemotherapy one time, and I'm not sure how long my fellows will be able to tell you. My postdoc fellows will be able to tell you how long they do it for. But and then after we do one titer read afterwards. If there are hits in there, then we can interrogate that further by selecting those drugs and doing standard IC50 curves. But it is a initial screen. It is completely agnostic to the variants. In all honesty, patients don't really care why it works. They just want a drug that works. And so this gives you a panel of drugs that then we feed that information. Again, as I said, from the high throughput drug screen, we've collaborated with a machine learning drug repurposing pipeline at the Wyss Institute, where we take that information, integrate it with this the transcriptomic data to really identify which of the 120 drugs that work out of the 3,000 are most likely to work in this disease. And that's what we use for. That's what we use for our organ chip.
Fantastic, fantastic. We're coming up on the hour, so we're going to close out the presentation. Lorenzo Ferri, honestly, really congratulations, really fantastic work. And I think you might end up with more collaborators after today's presentation. So thank you for joining us. Thanks everyone for your participation in Medical Grand Rounds. Thanks Lorenzo for being here today. Really fantastic presentation.
Thanks so much.
Thank you. Bye-bye.